So this video is regarding coagulation disorders. So we'll start out with just a very brief review of coagulation. If you remember from hemostasis and coagulation in physiology, there are a bunch of factors that lead to blood clotting that are circulating in the blood in an inactive form, and and then they're activated. It would take too long to make the clotting proteins that are necessary if we waited until we actually needed to clot. So instead, the liver mostly makes inactive forms of these proteins that become activated by enzymes and are available where and when they're needed. All of these inactive forms of proteins either have the prefix pro or the suffix gen, as in generate or genesis, the formation of. So fibrinogen is inactive form of fibrin. Plasminogen is the inactive form of plasmin. Prothrombin is the inactive form of thrombin, etc. Like I say, most of this stuff is synthesized in the liver. So a lot of these symptoms are also the same symptoms of liver disease, because we get these coagulation disorders as secondary to liver disease. This is, however, we're going to talk about a couple of primary things. Vitamin K is important, and again, if there's a deficiency in vitamin K, then these factors are not normally functioning or even synthesized. And we're talking about the whole clotting cascade. So this is forming the clot and then removing the clot when it's no longer necessary, fibrinolysis. There are things like heparin that are used to prevent the formation of new clots, but they don't do anything to lyse the existing clots. And so it becomes very useful, because we're going to see that removing clots can be problematic in and of itself. So a quick review will tell us that there are two pathways. There's the intrinsic pathway to clotting, and there's the extrinsic pathway to clotting. In the intrinsic pathway to clotting, all of the factors that are involved are found within the blood. So the blood will coagulate in a test tube outside of the body, or on the sidewalk if you bled out onto the pavement, because the blood contains its own factors to clot. However, there's multiple steps and multiple factors, and so it takes a long time. The intrinsic pathway is triggered by factors that exist outside of the blood, so in the tissues, and we call those tissue factors. So with the extrinsic pathway, we are relying on tissue factors. So this happens within the body, and even though it's called extrinsic, because it's extrinsic to the blood. So the tissue factors in calcium, and then a couple of other factors, all lead to factor 10 becoming 10A. And the numbering of the factors is the numbering on which they were found and discovered and described, not the order in which we use them. But nevertheless, it all ultimately leads to this common pathway, which makes prothrombin, a protein, become thrombin. Now, thrombin is an enzyme that causes fibrinogen to become fibrin. So the globular fibrinogen becomes the fibrous protein fibrin, which makes a net which catches proteins and the formed elements of blood and creates the clot. And if you remember, even though it's not here, that there are platelets that are caught up in the clot, and after the clot forms, the platelets contract with actin and myosin overlapping, and they will contract and pull the edges of the wound closer together and squeeze the liquid out of the clot. So the clot at first is very jello-like, and then it becomes much more solid half an hour later when the platelets entrapped pull on the fibrin mesh and make it be a clot like we're more understanding of or more used to seeing. So these primary coagulation disorders is a problem with this. So this could be inappropriate lysis, which causes bleeding, or inappropriate formation of the fibrin, so that we have the vascular spasm and the platelet plugs, but then the fibrin doesn't actually cause the clotting. So either way, we can have bleeding. So either we don't form the clots or we remove them too quickly. The other thing that can happen is inappropriate activation of the clotting cascade, and then we end up with excessive clot formation, and that can occlude blood flow. So this could be things like the release of too much tissue factor for whatever reason. It's usually some sort of an inflammatory reason on the walls of the blood vessels, and we have inappropriate clotting. The two disorders that we're going to talk about in some level of detail are hemophilia and disseminated intravascular coagulation, DIC. Now, hemophilia has a couple of different forms, but they're inherited. And they are really some sort of abnormal functioning of either factor 8 or factor 9. And that interferes with the intrinsic pathway of coagulation. The extrinsic pathway is what we rely on. So the intrinsic is that which happens in the blood. And so then fibrin clots either don't appear, or they appear late, or they are incomplete. In any case, we end up with a bleeding disorder, and hemophilia really means a bleeding disorder. It kind of really means loves bleeding. So there's hemophilia A and therefore hemophilia B. Hemophilia A is common, it's the most common of them, and is a problem with factor 8. And it's a recessive X-linked disorder. So that means that it's a recessive gene on the X chromosome. So it is possible for women to have it if the father has it and the mother is a carrier. So two X chromosomes both with the deficient gene will allow this to happen. It's more common to be found in males because all we need to have is an asymptomatic carrier mother, because the father doesn't contribute a chromosome to a son. It doesn't contribute an X chromosome to a son, just the mother does. And so this is how it's It is. It's a lot like muscular dystrophy. This is the hemophilia that's found in the royal families of Europe. This is the one that the Tsarevich in Russia in the early 1900s had. Mother was a carrier. Christmas disease, hemophilia B, is less common, and it's a problem with factor 9. And in both of these cases, what you do is you just treat with supplementing the factors. Now, in the old days, they didn't know what these factors were, let alone being able to synthesize them to use as therapy. So these children often died prematurely from bleeding disorders. I'm sorry. And it's probably fairly famous because of the number of carriers there are in royal families. And remember that the Tsar of Russia and his wife, Alexandria, were cousins, and they were both related to Queen Victoria. And they were first cousins with the Kaiser Wilhelm of Germany and the King of England at the time. And so a lot of minor princes and nobility right across Europe, all because of these shared bloodlines, carry this as a recessive gene. So, what's going to happen? It's a bleeding disorder, so it's very easy to bruise. So, what would normally cause a blood vessel damage that would clot very quickly doesn't, so bruises form. You get prolonged bleeding from oral or nasal mucosa, so bleeding noses that don't stop. Dental work will bleed for a long time. We can end up with these hematomas, bleeds into deep tissue, and the blood gets encapsulated and becomes like a blood tumor, a hematoma. It says hemiarthrosis. I think it's supposed to say hemarthrosis. I notice hemarthrosis. It means bleeding into the joint. So the synovial membranes of every joint, every synovial joint, are actually very highly vascularized and actually very exposed, and so they can be bumped and because of this bleeding disorder, the blood can go into the synovial fluid, and it can cause joint damage. So if this happens enough, it causes inflammation, it causes a lack of lubrication, and it can cause deformations in the joint. Now remember, these are congenital genetic issues. They're there from an early age, so during growth and during childhood. And so joints will become very deformed because of when it happens. A lot of times there's bleeding into the muscles, especially in the extremities, because you use the muscles of the extremities more. You can have hematuria, blood in the urine, and it happens spontaneously, necessarily without infections, bladder infections, and that kind of thing. GI bleeds are really important and can be fatal, for that matter. The slightest bit of abrasion anywhere in the GI tract or ulcerations, just from stress, can cause bleeds that will go on for a long time. And with the concomitant loss of blood and anemia that follows that. Intracranial bleeds can be really dangerous too. You bang your head, and what would normally be maybe a small little bleed in the meninges can turn into quite a substantial bleed and maybe a hematoma within the skull, and put a lot of pressure on the brain and central nervous system, which in and of itself is a very, very dangerous thing. The other disorder we're going to talk about here is disseminated intravascular coagulation, DIC. Now, DIC is a very common thing. Statistics show, I believe, statistics show that upwards of about 1% of hospitalizations for anything will show this. So this means that you are definitely going to see this in clinical practice, often in not too severe a form, but nevertheless, this can be a real problem. It all starts with some sort of a triggering event, something that causes inflammation of the walls of the blood vessels. So this could be a septicemia, like an infection that becomes bloodborne. Snake bite is a common thing. Cancer, things like that. That anything that can cause inflammation of the blood vessel, which can release tissue factors, which activates this whole coagulation cascade, especially the extrinsic pathway. And what you end up is prothrombin becoming thrombin, which makes fibrinogen become fibrin, which causes clots to form. And so you get these small little clots. So some of them are attached to the blood vessels, and so they would be microthrombi, and some of them are freely moving, which will become microemboli. In either case, these clots, and because they often happen in the very small arterioles, because that's where the inflammation seems to be, we end up with vascular occlusion and ischemia from the lack of blood being able to flow past these clots, especially if they're microemboli, because the clot will move forward until it reaches a blood vessel that is smaller than the diameter of the embolus of the clot itself. And anything distal to there will then become ischemic. And that ischemia can be quite damaging to the tissue that is being perfused by the blood that's blocked. And this becomes of particular importance in the viscera, in the organs. But something else happens here. As all of these, and disseminated, it happens and throughout the entire cardiovascular system. Disseminated means all over the body. What it happens is that all of this clot formation starts using up the clotting factors. So that clotting factors, like the prothrombin and the fibrinogen, and all the different, like factors 8 and factors 9 and factors 10, all get used up because there's only so much of it to go around, and all of these little inappropriate clotting cascades use up these things. It uses up the platelets because they are all trapped in the fibrin meshes and makes these thrombi. And so therefore, we can't have appropriate clotting, and so we can end up with excessive bleeding. And when you look at that, can be compounded with ischemia. So if there's ischemia, it causes inflammation and causes problems in the organs that are ischemic, and they'll probably start to bleed. And so we can lose quite a bit of blood, and it's a real problem, which can lead to sharp declines in blood pressure because of hemorrhaging. So it's hemorrhagic shock. And that sharp decline in blood pressure may be leading to heart failure because not enough blood actually gets back to the heart. Those can be a real problem. Another problem is that all the plasmin made by the plasminogen, which is also released by excessive amounts of. So plasminogen becomes plasmin based on prothrombin becoming thrombin. So the prothrombin becoming thrombin directly causes fibrinogen to become fibrin, and then more slowly it causes plasminogen to become plasmin that removes the clot, so that the clots form and the formation stops and starts to reverse in a balance, so that we don't excessively clot. Well, what ends up happening is that the excessive amounts of prothrombin becoming thrombin causes excessive amounts of plasminogen, and there's all these clots to work on because it's disseminated everywhere, and so we get fibrinolysis happening everywhere. And when the fibrinolysis breaks up the fibrin, it does sort of break up the clots, but we end up with too many of this scrap leftover partial fragments of fibrin, the split products, and that can really interfere with, again, with more clotting. So not only is there less fibrinogen around because it's been used up, there's more excessive products, kind of as it were the scrap, and this contributes to excessive bleeding, and these people will actually can go into shock because of it. So it's a bit of it's hard to wrap your head around this, but excessive clotting leads to excessive bleeding. And a lot of the times that's what you're going to be seeing and treating is this excessive bleeding. So it's an acquired thing. You get it from a triggering event. It can be an acute, or it can be a chronic, from some sort of chronic inflammatory condition. You get excessive bleeding and irregular coagulation at the same time. So you get inappropriate clotting and inappropriate bleeding because of it. The clotting, so the clotting happens disseminated. It's throughout the entire body, and it's usually in the small arterioles that feed capillary beds, and so will cause ischemia in those beds. Then the clotting factors and the platelets get used up, and then the end result is excessive bleeding. And like I said, this can be either an acute one-off because of an acute trigger, or it can be chronic because of chronic inflammatory type issues. And you are going to see it because it's probably a higher percentage in hospitalized people because they have more of these triggering conditions, more of these inflammatory conditions. So we'll see it more than in the general population. So whatever this trigger is, it causes a damage to the endothelium, and you release the procoagulants, the tissue factors, into the blood. You get intravascular clotting. You use up the factors. You activate the fibrolytic to break down clots, and then you get the hemorrhage because of coagulation, anticoagulation, and fibrinolysis all happening more or less simultaneously in really excessive numbers. So what do you see what are you going to look for when you see people with this? There's going to be bleeding into the skin, so you're going to get little petechiae, little broken blood vessels and bleeding into the skin. Ecchymosis, skin and mucous membranes, so in the mouth and in mucous membranes. Bleeding from orifices will be an issue, especially nosebleeds. Any injuries, so a cut or venipuncture will bleed and bleed and bleed. We get this acrocyanosis. Remember, acro means extremities. Cyanosis means turning blue. So it's an ischemia in the extremities. So you get these cold to the touch, mottled fingers and toes. And that's because of the ischemia, because of the microthrombi in the vessels of the extremities. And it's going to happen in the extremities more and in the organs, because that's where the majority of blood has to go to. We also can have problems in pulmonary microcirculation. So thrombi forming in the blood vessels that feed the alveoli. And so then you get concomitant respiratory issues, and you get the clinical manifestations of that. And it can be the same as pulmonary emboli, that kind of thing. A really important factor is that renal microcirculation can become bad, and like into the glomerulus of the kidneys, which will lead to acute renal failure. And so this can be a very real problem, and this can cascade out of control very quickly. It can become life-threatening. So we get this excessive bleeding and excessive clotting happening simultaneously. This poor kid's hand here, like, is what we're looking at. These are the petechiae here. Burns, traumas, severe infections, and snake bite, venoms can do this. Spider bites can do this. One would have to think that if you were practicing in Australia with the number of venomous creatures there, you would be paying a lot more attention. This is how the venom works, actually, in a lot of things. Another place we see it a lot is in toxemia and eclampsia, preeclampsia, in obstetrics. Amniotic fluid embolus will do it. Abruptoplacenta, so that's when the placenta comes away from the uterus, can cause this. Carcinoma is a big problem, and you will see it around that too. So how do we treat this? So these are the petechia, by the way, on this foot. So we treat it by treating the imbalance. So if we're at the hemorrhage stage, then we better help deal with the hemorrhages. If it's at the thrombosis stage, then we better deal with the ischemia and that kind of thing. So you have to treat the underlying cause, and then you have to replace what's missing, basically, these clotting factors that are missing. So this could be an acute, somewhat mild thing to a very severe life-threatening thing, and it depends on the primary problem. It depends on what the triggering event is and how quickly this disseminates and goes everywhere.